Welcome to Aging for the Nurse Practitioner. So there's going to be a lot of different things in here. There's going to be a lot of sort of geriatrics, gerontology, as well as some sociology. So I think it's all useful stuff for the primary care role, and we'll kind of do the best we can. And I did do this in two different sections. This is part A, and you do need to also listen to part B to get the full talk. So we'll start off with what I call a philosophical question. There's 3 or 4 terms that are used when we talk about care of the elderly. A lot of times in nursing we talk about gerontology, which is just the study of the elderly. Physician practices are more likely to talk about geriatrics, which is specific to medical care of the elderly. Sometimes a term called gerontics is used. It was actually developed by nursing, but is used most commonly now by occupational therapy. And the other term that is sometimes used as a more generic term is aging. So when I was at the University of New England, we had the Division on Aging, which included a multidisciplinary staff, and so a number of different ways can be used to conceptualize it. There is a subtle difference in the way it's conceptualized. If you conceptualize it as geriatrics, then you're going to focus on the medical care. The folks that do gerontology focus on the fact that 90+% of elderly do successfully age and really don't need much for medical care. So in our role, we're going to see disproportionately the amount of people that are seeking health care. So I tend to use the term geriatrics more, but just so that you're aware that there is some controversy there. You've probably seen this slide or a variant of it a number of different times. The silver tsunami, the aging of the population. At any rate, we definitely have an increase in age, probably mostly related to the baby boomers. But we are going to have more and more elderly folks to take care of over time. And so, we're probably at the 50 million point where 1 out of every 6 or 7 people is over 65, and that will continue to increase as time goes on. Now, when we talk about aging, I think it's really important to make a clear distinction of what we mean by normal aging. A lot of people will throw out lab values that change or functional decline as an evidence of normal aging. The problem with that is that not everybody gets that. A lot of people do maintain great function for long periods of time. On average, we do see a decline, but that doesn't mean that you can actually apply that statistical average to each and every patient. So just be very careful using the term normal aging, just because I would encourage you to do a differential diagnosis of other pathology that might be causing those problems before you settle on the fact that something is a normal decline of aging. There are lots of people who are still very highly functional. This lady, Fufi Harlan, was on a lot of different journals, and this is a picture from the New York Times back in the 1990s. She was 76 years old at the time, and clearly she did not have a decline in her flexibility related to aging, and was actually in great shape, lived to be into her 90s, and is an example of a successful ager. So again, we can go back and we can look at aging as statistical norms. Sugar metabolism does slow down, and you are more likely to have a lot of folks that do fall into the category of pre-diabetes or even diabetes, but a lot of the folks that have the slowing into the pre-diabetes range may never get to the point of actually being diabetic. So I always reflex anything over 100 for a sugar to an A1C. I'm always surprised by the number of people whose A1Cs are still normal. Their sugar metabolism is slowed, but on average, they're doing really well with sugar metabolism. We do definitely see a decline in cognitive function. If you do sort of psychological testing on people, response times, a number of different things are slowed as we age. That does not mean that everybody is on the road to dementia. It does not mean that everybody is functionally impaired cognitively. But it does mean that as we get a little bit older, memories might decrease a little bit and processing time is going to increase. So we need to consider that in regards to some of our interventions. On the other hand, again, I would discourage you from generalizing to any individual based on these statistical norms. So, you know, the advantage of having these statistical norms is that if someone does have a very slight decline in their kidney function and they're older, we're not necessarily going to panic and be looking for major issues in their kidneys. On the other hand, the other side of that is that if we ignore abnormalities of kidneys, we're potentially missing out on an opportunity to cut back on their NSAID use or to otherwise address their risk factors for kidney disease and improve their function. Lifespan is the maximum time that a species can live. You know, it's probably about 125. There was one lady named Jean-Louise Calmette who did live to be 122 years, 164 days. She's the longest documented life so far. And so that's probably going to be the maximum that we think humans can reach. Life expectancy, however, is a very different thing. That's giving a population and looking at all the different factors, how long on average would that person be expected to live? We often report it by country, and that's useful to think of in regards to public policies for those countries. But we can also look at it by age. You know, we know that the life expectancy in the United States is, you know, roughly 80 years old. You can't really use that to try to figure out what's going on with an 85-year-old male. You can't say his life expectancy is -5 years. In fact, if we look at all the 85-year-old men, on average, they're going to live another 5.7 years. Someone makes it to 100, life expectancy is around 2 years. So, you know, it can be a useful thing to think about how much longer they're going to live. If you look at the you know, the people who live the longest, life expectancy-wise, you can see that the United States is not one of the top ones. We can see that Sweden, people live an extra year or two longer than we do. Japan, probably a year and a half, and then on Okinawa, they actually probably live closer to 2 years longer than we do. Again, I think this is really important when we look at public policy issues. The Scandinavian countries almost universally have longer life expectancies than we do, and I think there's a number of different factors you know, that are related to that, some health related, some only partially health related to social norms. You know, gun violence, of course, is substantially lower in the Scandinavian countries, so the risk of dying of a gunshot wound is substantially more in the United States than it is in any of these countries, but you know, something that we need to keep in mind as well. When we look at the sort of, you know, big three countries in the world, Russia, China, and the United States, you know, we can see that the United States still does lead as far as life expectancy. The life expectancy difference has substantially narrowed between the United States and China. In China, in 1960, for example, the average American was expected to live to be about 70. In China, the life expectancy was just a little bit over 40. Now we see that the life expectancy in China is about 75 and about 79 in the United States. So the Chinese have done an amazing job of prolonging their life expectancy. The Russian Federation, we can see that there's been some ups and downs. We do see that around 1989, when the USSR broke up, there was a decline in their life expectancy, but only a matter of a few years. And we can see that in 2010, they've reachieved that number. And we can see that they're clearly on an upswing, and that I would expect their life expectancy to continue to improve over time. When we look at why people age, I don't think there's a really good answer biologically. There does seem to be some information and some basic science work going on, but I don't think that that work has really produced anything that is particularly clinically useful. There is the Hayflick phenomenon that notes that the average cell will reproduce about 50 times in a lifetime. This is probably most important in regards to research on cancer. Cancer is clearly an exception to that 50 times. Cancer cells continue to split and reproduce and are really not well controlled. There's a lot of theories that are going on in regards to why that may be. The telomerase, which is the enzyme that kind of breaks down telomeres, seems to be malfunctioning in the cancer patients. There may be something to be learned in regards to overall aging if we can affect that function such that we can prolong life without causing uncontrolled division like there is in cancer. So necrosis and apoptosis are actually terms that are used a lot that not necessarily everybody understands. Necrosis is when there's death before the normal lifespan has been lived out. So apoptosis is that cell that has divided 50 times and is just not going to divide anymore. Necrosis is some kind of death caused by usually some sort of external force. So again, there's a lot of theories of aging. Most of them fall into the general categories of a program theory, which is the fact that there is a gene or some sort of process in the organism which says that it will age to a certain point and then die. The stochastic kind of means random theories infer that there's some sort of random events out there that are damaging the organisms, and that without those events, organisms would potentially live substantially longer, maybe forever. And you know, we can see that you know, there's not really a whole lot of clinical implication for any of these. There is a lot of interest in metabolic rate. If we slow metabolic rate, does the organism live longer? We have some evidence from, you know, various animals. A mouse has a fast metabolic rate and a short lifespan, and an elephant has a slow metabolic rate and a long lifespan. But there's definitely some animals that are exceptions to this. The loose cannon theory is a stochastic theory, which had a lot of play back in the 1980s and early 90s, in which the big nemesis, if you will, was free radicals. Free radicals are basically hydrogen ions. So basically an ion that exists that is going to pull electrons away from some kind of other tissue. The big thing was, oh my gosh, you're taking in a lot of free radicals. That's going to cause premature aging. Linus Pauling and the folks that were really pushing the vitamin C supplements were suggesting that all of those could slow aging. The you know, the later research and the actual evidence now is that there really is not much, if anything, to these theories. Unfortunately, like many theories that are hot in the media, it's really hard to get that theory to be looked at realistically. And there are still a lot of the folks that are selling vitamins that are very much pushing the fact that vitamins can decrease free radicals. That does not change the fact that we really have no idea whether decreasing free radicals has any real long-term benefit. So, weak link theory, basically saying that some organisms have evolved traits for longevity. It is really interesting to me because if you think about survival of a species, a trait of longevity is probably not going to really promote the survival of a species, because the older people are going to take away resources and nutrients from the younger folks who are still in their reproducing age. So if you look at pure adaptation and evolutionary theory, there is real pressure, if you will, not to develop genes that promote longevity. So that's an interesting thing. Longevity has been pretty much stalled as far as lifespan for many years. We have increased life expectancy based on mostly, to be honest with you, public health interventions, better water, those kinds of things. There are arguments that because healthcare kills the large number of people that it kills, if you took away all healthcare except for antibiotics, you'd actually prolong the life expectancy of humans substantially. But, that's a theory, of course. Another set of theories relate to DNA. Basically, the error catastrophe theory says that eventually there's going to be some kind of a mutation, some kind of a misconnection of the DNA, and that's going to damage the organism. And then, of course, the other DNA-related theory is that there are gerontogenes, genes that basically are there, which promote the decline and death of the organism, which again would have a certain amount of evolutionary adaptation. So when I started studying geriatrics gerontology back in the late 90s, early 80s, late 80s, early 90s, I ran across a lot of different theories, a lot of different things, and I've sort of collected a bunch of those into what I call my principles of geriatrics. None of these are particularly original. You can find them all somewhere else, but I don't know that anybody has put these 8 things together exactly like this before. So we'll talk about altered presentation. We'll talk about the fact that not all elderly get exactly the same symptoms as do younger folks. We'll talk a little bit about homeostenosis, which is just a narrowing of the responsibility as one ages, usually related to quote-unquote normal aging changes, but resulting in a decreased ability to adapt to illness. We'll talk about the fact that we need to assume something is pathology until other causes are ruled out. And then we might want to attribute it as a normal change of aging. We also know that when people are in their 80s, they've accumulated a lot of illnesses, a lot of injuries, and that it's just the fact that they've lived so long and accumulated all these injuries, more so just than the fact of being 80. We also need to think about the fact that as one ages, the priority is not necessarily living a long time, it's functioning as long as you possibly can. So that means that we will sometimes make different decisions. If I have a 35-year-old who's having some aches and pains related to their statin, I'm going to try some CoQ10. I'm going to try a lot of different things that I'll switch their statin to 2 or 3 different kinds. Just because if they've got, I had a patient come in last week that had an LDL of 257. This lady is at great risk of having a cardiac event, and I do think that we can, really decrease her risk by having her on a statin. I think it's a very different thing when you have someone who is in their 80s, especially if they don't have a lot of family history of cardiac disease. I'm going to focus very much more on function for that person. I'm going to function on function for everybody, but it'll be even more of a priority. as someone gets older. Life stage issues as people age, there's lots of times lots of losses, lots of changes, so that's something we definitely need to have to consider. Start low, go slow is something that a lot of geriatric pharmacology courses will definitely emphasize. I, I did add the but go, which is something that a number of other folks have added over the years as well. And that's basically saying that if you start low with a blood pressure medicine, go up gradually, but make sure that you do try to achieve a reasonable blood pressure. Again, we now know based on JNC 8 and some other recommendations that we might not want to be quite as aggressive with blood pressure control related to falls and other side effects, period. We're definitely going to hope for the best but plan for the worst. We're going to plan for advanced directives and those kinds of things, but either way. So to specifically talk about some of the altered presentation issues, it's not uncommon at all for an elderly person to present with a urinary tract infection or pneumonia or some other infection that in a younger person would have caused a temperature of 101 or 102, and the elderly person not to have a fever at all or to have a very low-grade fever. So that just means that you need to be diligent. You need to be looking for other signs of infection, abnormal white count, and especially the abnormal differential, since even the regular white count doesn't always change. The differential usually will change. Whenever someone presents with confusion, you want to consider the possibility that this is a presentation of either a urinary tract infection, possibly a low-grade pneumonia, some other physiologic issue which is interfering with the brain function. It's also not uncommon for an elderly person to present with shortness of breath as the primary symptom of a heart attack. As a matter of fact, chest pain becomes progressively less common as you get older. So sometimes it's malaise, sometimes it's fatigue. You just need to be vigilant. Those working in an emergency department know that anytime elderly people come in with a number of different complaints, you're going to kick in that sort of soft rule out, do some troponins, really look for some signs of some sort of cardiac event. The next one, underreporting of symptoms, is very counterintuitive for people, just because usually when you have an elderly person, it seems like all they do is complain of their ills. Because of that, however, a number of them start minimizing and not complaining about things, so that they'll have pain, they'll have shortness of breath, they'll have a number of different things, but they'll just attribute them to normal aging, and they'll just not even report them. So it is a double-edged sword where you have that person come in and it seems like they have a completely positive review of systems, everything's positive, but be vigilant, and it can take a long time to do a differential diagnosis process for each and every one of those. Lots of times I'll set priorities for probably 2 of the most important ones, as long as there's not risk of delaying some of the others, and then I'll work on those, and until we get those sort of worked up, I'll put the joint pain and some of the other things down as secondary. So falls are something we always need to be vigilant for in the elderly. They are way more common than you think they are. We'll talk about falls in a talk a little bit later in the semester. But when you think about it, you and I often fall in the course of a year once or twice. And unfortunately, when you're older and when your bones are a little thinner, if you fall, the sequelae of that is going to be substantially more. When one has vague symptoms, one also needs to be vigilant about doing appropriate laboratory assessment. You don't want to label people as complainers. Usually there is some kind of reason that they're complaining. So you will need to be diligent. Depression is definitely not uncommon in this population, but depression is really a diagnosis of exclusion once you've ruled out most of the physiologic causes. I am surprised how many times I see an elderly person who has depression. They've been started on a depression medicine, and then I do some labs on them, and I find that their sugars are off, or their thyroid's off, or something is off that maybe could have caused those symptoms. And we fix what it is, and sometimes the depression completely goes away, or at least it often decreases. So decreased appetite is another thing that you do want to be thinking about what kind of a differential diagnosis that you'll have and what kind of a workup that you're going to do. It is a not infrequent complaint. It sometimes is something of an ominous complaint, and sometimes you do need to do a cancer survey, where you're even doing CAT scans of the head, chest, abdomen, and pelvis to look for some sort of occult cancer to see if there's something that can be done for it before it gets too severe. Homeostenosis, as we said, is basically just that decreased reserve, so that if I am elderly and my blood pressure is normal at rest, but then I have increased stress on my system, I won't necessarily be able to get my pulse up high enough to keep my blood pressure where it should be. So for me, that is an issue sometimes with threshold for treatment. If I have an elderly person come in, they've been coughing, and I'm on the fence as far as treating them for a bronchitis or a sinus infection, I might be a little bit more likely to go ahead and treat them to give them that extra boost, just because I know that they're not going to be able to possibly mount the same kind of resistance that they would have when they were younger. So again, assume something is pathology until otherwise proven. The classic story is Jack Rowe was a geriatrician that started one of the first geriatric programs down in New York, and he had an elderly patient come in, and the patient said, "Doc, my knee hurts." And Jack said, "Well, you're 90. I guess we might have to expect that your knee is going to hurt." And the patient said, "But my other knee is 90 as well, and it doesn't hurt." So basically, at that point, you want to do an evaluation, looking for osteoarthritis, looking for other possible things. And we definitely do more knee injections. There's the Synvisc type medications that can be used for osteoarthritis. You can do a partial knee replacement now, or you could even do a knee replacement. When someone's 90, you want to be as least invasive as you can. On the other hand, if they're 90 and their quality of life is awful, I had an 87-year-old man come in not long ago who had horrible hip pain, and on x-ray he had actually had a compression screw years ago, when the screw had worked through and was actually scratching his acetabulum every time he moved. We completely replaced his hip. One of the orthopedic surgeons did a complete hip replacement, and the man's quality of life is dramatically better now. So loss of Achilles reflex is another example. It is something that, because as you get older, you lose some of the elastin in your tendons. You can't give the quick stretch to the tendon, so you will lose that Achilles reflex. However, if it's asymmetric, if it's sudden onset, if there's something else going on, it might be a sign of some sort of neurologic process. So make sure you think through the neurologic pathology that might be affiliated first before you settle on quote-unquote normal aging. So some other sayings that have happened in geriatrics, one of those is related to accumulation. It was on the wall when I did a site visit down at the UMDNJ site down in Cherry Hill, New Jersey. One of the geriatric fellows had this on his wall, and I think it's actually a pretty good saying. You're sick because you're sick, you're old because you're old, you're not sick because you're old. So make sure that if someone is sick, you want to address their illnesses and treat them to the greatest extent possible, dealing with the fact that they are aging as somewhat of a separate issue. When we focus on function in the elderly, I think it's really important to recognize that function is whatever the elderly person says it is. So the quality of life is what they define it as. So basically, you know, I had a sign over my desk when I was at the University of New England. It's about function, stupid. And basically, we want to keep elderly folks as happy and as functional for as long as they possibly can be. Sometimes that means, you know, medical interventions that are going to keep their blood pressure in a place where they're not going to have a stroke. On the other hand, being more aggressive and having them end up with a fall is not useful either. There was a study a year or two ago that basically said lower is better for blood pressure. The problem is that they did not really show that the other issues, such as falls, did not occur at those more aggressive levels, as well as noting that the more aggressiveness is going to end up probably having substantial side effects, and the fact that they had a very specific population that had multiple medical issues as opposed to just hypertension. So at any rate, you know, we'll talk about that study later on. Life stage issues. This is actually something that you do need to review for the nurse practitioner boards. There is sometimes things on Erickson, you know, the 8 stages of man, as well as some other life stage issues. I think that for me, you know, this is one of the Erickson stages that seems the most intuitive for me, and basically it is truly ego, integrity versus despair. So we've all seen that elderly person that's a successful ager, that's still functioning, that still has meaning to their life, but we also see a lot of people who are in a stage of despair where they really don't feel like there's a lot of meaning to their life, and they constantly talk about dying. Another read that is probably worth it is Mary Pfeiffer's. Mary Pfeiffer, of course, is known in women's studies for the you know, the Ophelia book. She also wrote a book about aging that's called Another Country, and basically she talks about the fact that most people, as they age, really do feel like they've traveled to another country. The terminology seems to have changed, so they feel like they're in another country. They don't know how to manage, how to get around. A lot of the things that you or I would experience if we were just picked up and plunked in another country. It is probably a pretty good analogy for aging. Start low, go slow. You know, in general, we're going to do this with pharmacology. It is important to remember that some drugs actually require higher doses. Beta blockers, for example, you might need a higher dose to get the same effect. So, you know, you just need to titrate to effect, keeping an eye on side effects and risks of side effects as well. But, you know, don't be hesitant to go up a little bit and see if you can get the effect that you want, constantly reminding yourself of potential side effects and potential downsides of these kinds of things as well. So in general, we're going to hope for the best but plan for the worst. Patients very often have difficulty understanding exactly what advance directives are. I often have people come in and I ask them if they have an advance directive, and they say, yep, I did it when I did my will. It's in my safe deposit box. And I, you know, explain to them that if they're in the emergency room and they're trying to decide what to do for resuscitation, they're probably not going to call the bank to get that advance directive, that they really need to bring in a copy of that advance directive. We need to scan it into their chart so that we have it readily available. They also don't understand the difference between a living will and a durable power of healthcare attorney. Living wills are really sort of useful for clinicians to get a sense of what a patient's ideas and beliefs are. Neither of these are particularly binding on a clinician, however. Really, a no-code order is written by a physician, nurse practitioner, or PA. Depending on the state and depending on what the legalities are. In Maine, NPs can write no court orders and initiate what they call a POLST, provider order for life-sustaining treatment, the POLST. But the living will gives you an idea of what the patient wants, but it really is the clinician that is going to make the decision in regards to how aggressive to be. A durable power of healthcare attorney does designate a specific person to make decisions for the elder in case they are unable to make their own decisions. This is specifically a power of attorney only for healthcare. A number of elders, once they get especially into their very advanced ages, will have a complete power of attorney which authorize one of their children or someone else to make all legal decisions for them. But this really is very specific for healthcare, and I think it's really important for an elder to have this, and it provides you some cover, if you will, if an elderly person lives alone, they have 3 children, and the 3 children have very different ideas about how aggressive to be. If the elder has designated somebody as their DPOHA, that person's insights should take priority. So for comprehensive geriatric assessment, we're going to need to make sure with an elderly person that we've considered functional and cognitive issues to probably a greater extent than we do with younger folks. So when we do that annual evaluation, we do need to factor those things in. Now, Medicare has never really paid for annual physicals, and they still sort of don't. They pay for what they call the initial preventive physical examination, what we often call the Welcome to Medicare physical. But after that, they pay for what they call an annual wellness visit, or an AWV. The annual wellness visit does not necessarily include any sort of a physical examination. It has a number of different preventative functions that it is supposed to include, including assessing for falls, assessing for social issues, assessing for a number of different things. That's a sort of a paradigm shift for clinicians, however, and a number of clinicians have a hard time actually making that shift. So it is something that you do want to factor into your annual evaluations, period. When you do that H&P, you're going to look at function, you're going to look at activities of daily living and instrumental activities of daily living. In a couple of slides, I'll talk about some scales that can be used to do that. And also you're going to try to get a more extensive cognitive and mental health evaluation. So just to reiterate the IPPV, the Welcome to Medicare physical, that does include a cardiogram. They will pay for an EKG as part of that. And if you have a male who has smoked more than 100 cigarettes in their life, they will also pay for an ultrasound AAA screening. The risk of AAAs is substantially lower in women, so Medicare will not pay for it in women. They will pay for this ultrasound even if it's done at a subsequent AWV, but they'll only pay for one between the ages of 65 and 75. The next year after age 65, one would just have the sort of initial annual wellness visit. Not going to talk a lot about coding here, but there is a substantial difference in the RVUs for the Welcome to Medicare visit, the initial annual wellness visit, and then the subsequent annual wellness visits. So, as you get further along in your career and you're looking at coding and RVUs and those kinds of things, you'll definitely want to understand this. Right now, we're just going to focus on sort of the clinical aspects of that. So when you take a history in an elderly person, can it or should it be different than taking a history in a younger person? It's a really interesting question. There definitely are some cohort issues. The folks who are in their 80s now when they were younger and they went to the doctor, it was very much of a doctor-driven experience. They went, and I have a number of different people who, when I ask them about symptoms, they will tell me that they had a certain symptom, and I'll say, well, why didn't you tell me that? And they'll be like, well, you're the doctor. You're supposed to ask me and figure out what's going on. So the insight is not the same for those folks. For one thing, they often don't really fully understand the fact that non-physicians are providing the kind of care that physicians used to provide, and they want to call you doctor. But they also have an idea that you really should be figuring things out. So you don't want to make some very specific inquiries about things. Don't assume if a patient has had a particular symptom that they'll tell you about it. So communication issues, obviously there's hearing issues, there's terminology issues, there's all sorts of different things that you need to take into consideration. These are skills that you'll develop by working with elders, but that you do need to be very deliberately aware of. The volume of their history is also substantial. So some folks will book a 30-minute physical for anybody under 50, and then a 45-minute physical for anybody over 50. The other thing that you sometimes have to do is you do have to bring them back for additional visits to really figure out exactly what's going on. I have really mixed feelings about getting a lot of history from old records. I find that they're often wrong. I find that they're often making assumptions of things that I need to go back and validate that turn out not to have been correct. So it's not a bad thing necessarily to look at old records, but as I say, I heartily encourage you to go in with an open mind and be thinking about the things that you think should be the priorities. Just a basic review of the things that are included in the history as far as the history and physical, HPI, PMH, past medical history, family history, social history, review of systems, meds and allergies, and we'll talk specifically about each of those. So for HPI, I do think that either old carts or OPQ or RSTU still work very well in this age group. Again, you're going to have to very specifically ask them about those things. I always do this first before I review their past medical history. Some folks like to review the past medical history because they feel it provides a context for these symptoms. I prefer to get the HPI and find out what they think is going on first. Then I go back and I try to compare it to what other folks have suggested for their history. So just to review, OPQ, RSTU, are other people sick? You actually don't get that in old carts. Provocative and palliative, you get that with old carts, but it's called something different. Quality and quantity, again, I'm not sure you get quite as much for quality of the pain. Region, radiation, recurrence, severity and other symptoms, timing and temporality. Temporality, of course, is what part of the day that it occurs in. So timing is how long it's been happening. Temporality is, do you get it every morning? Do you get it every night? That kind of thing. Previous treatments, what have you done for it? What has been prescribed for this? And something that the folks from Indiana University added to at a conference that I was at a few years ago. They started asking people, what do you think is wrong? And this can be amazingly helpful with a number of different folks, just because they're like, I think I have Lyme disease, or I think I have cancer, or I think I have whatever. And it really gives you an idea of what their agenda is, and you can consider that in your workup and evaluation. Old carts, I think you're all familiar with old carts. Just I put that on here so that it was there. Past medical history, different strategies with an elder. You can actually get the history just from the elder. You can try to get some info from the family. You can try to puzzle out what's going on with them by what medications the patient's been on previously. Again, be very cautious with doing that, just because there's a lot of medicines that we use off-label. If somebody's on Cymbalta, you don't know if they're on it for depression, anxiety, chronic pain. There's a whole bunch of different things that we can use Cymbalta for now. Lamictal, same thing. Is it for seizure disorder? Is it for bipolar? What's it for? You can look at their old records. Again, it takes a long time to really parse through those sometimes, as well as there's potential risk that other clinicians have jumped to conclusions, and those conclusions have just been carried continuously. Again, when you're doing history, you can try to do it as a menu, or you can actually go back and focus it on the specific problem that they've had. Immunizations are somewhat a bit of a challenge in elderly folks, just because it's not unusual for them to get immunizations that Medicare will not pay for. So you do need to know what Medicare will pay for and what they won't. Sometimes they have to sign a ABN, which is the notice that they may not get benefits for that immunization. But in general, Medicare will pay for the flu shot. In general, they'll pay for both pneumonia shots, both the Prevnar and the Pneumovax. In general, you want to give the Prevnar at the initial visit, the Welcome to Medicare physical, and then give the Pneumovax a year later. The recommendations are that you can give them 6 months apart. However, Medicare will not pay unless they are at least a year apart. So the pneumonia vaccine, you would not give it if it had been given in the previous 5 years, but if they've had it at some point in the past and it's been more than 5 years, you would again repeat it, again usually at age 66. The zoster vaccine definitely has some benefit, but is I think a relatively modest benefit. I always tell people that if they go to the pharmacy and hand them their card and it's going to be $10, I think it's a great investment. If it's going to be $300, then they have to consider the implications for them. Is it going to keep them from getting other of their medicines? Is it going to keep them from getting heating oil, those kinds of things. So I don't universally recommend it. Our office actually doesn't stock it because it does need to be kept frozen, and there is a fair amount of maintenance to that vaccine. Your office, when you get out, may keep it, but the reimbursement can be variable. If someone has a Medicare D prescription program, it may very well be covered, but it might not as well. The FDA says that anyone over 50 can get the vaccine. The CDC Immunization Practices Committee suggests it for anyone over 60. Again, different insurances will pay different amounts at different times. So the other thing that's kind of a quirk, I think, is that if you have someone who is elderly and they don't have any kind of an injury and you're giving it just to update, they will not pay for a Tdap or a TD. That being said, if someone comes in, they've had a scratch, they've had a cut, they've had any sort of an at-risk injury, in general, Medicare will pay for that Tdap. And I'm usually referring to Medicare B at this point. Medicare D programs, sometimes they do include it. I do always ask people if they are exposed to children under age 2. If they are, then I do really encourage the Tdap to make sure that they do have some pertussis coverage. But if they are not, then it is kind of dealer's choice depending on what they have for insurance and what kind of coverage they're going to get for that vaccine. So when you're doing family history, it's a really interesting question of whether it's even useful in this age group. If you've got somebody, her father died at 54 and she's 88, I don't know that we really care about that as far as, stratifying her risk for cardiac disease or other things. That being said, sometimes if you've got a woman who's 80 and her mother died of breast cancer at 82, then that might actually be an important thing to remember in regards to, whether or not you're going to screen. Obviously, there's various different times to stop screening with mammograms. Sometimes that screening is based on life expectancy. But I think also sometimes we do things to help people's quality of life, and if she's going to worry for the next year or so, it's something that you might want to really look into whether or not you can get it paid for or not for her. Social history, all the usual stuff that you would think of. You know, who are they living with? Are they living alone? Can they get out? What's their transportation issues? Do they have enough money to meet their needs? Have you done the advanced directives that you need? All the usual things in regards to smoking and alcohol. And we definitely will talk a little bit more about substance abuse in the next set of slides. Way more common than you think it might be, but also something that you do want to get a very specific assessment of. Sexual history, when you have someone who is over 65, a number of people will not bring up sexual issues. And to be honest with you, I kind of base it on the individual person and kind of what I take my cues from them, because sometimes they would be very embarrassed by it, I think. Other times they're very upset that you didn't discuss these kinds of things. The risk of all of the STDs are definitely climbing in people over 50. The number of people that are over 50 with HIV now is pretty substantial. You know, almost half, or at least 42% of the people with AIDS are over 50. So it is a cohort that does seem to be aging somewhat. Younger folks have been way more aware of safe sex practices, and so it is something to be thinking about as far as doing tests and considering screening if you have anything that makes you believe that there's a risk factor there, that you should do that. We also know that a number of people have been monogamous until their spouse dies, and so at maybe 70 or ages in which they're still pretty physiologically healthy, but now able to indulge in other sexual activities, they definitely may have greater risk of STDs. So if I have a single elderly person, I'll usually ask them if they have any sort of risk. And I do have a surprising number of folks that bring it up and ask for STD or STI or whichever term you'd like to use, testing. And again, as far as the number of folks that are still sexually active, a Spanish survey back in 2012 found that about 2/3 of men are still sexually active and about 1/3 of women. So it definitely, declines with age, but the number of folks that are still sexually active is pretty substantial, and you can't always assume. I've had people in their 80s that are still sexually active, and of course, you do have folks that are younger that have stopped being sexually active. So definitely something to think about in regards to when you're doing your histories in these folks. So this concludes this section. Make sure that you also listen to Part B.